Good evening, all. Good evening, all. I'm Dr. Sreenivasarao, Anesthesia Associate Professor, Medical College, Tirupati. Today, I want to share some points about the retinal spontaneous circulation. So, what is the retinal spontaneous circulation? Why we are worrying about the retinal spontaneous circulation? So, after doing successful CPR and defibrillation, and with the drugs, the patient recovers and the pulse will appear and all hemodynamic will appears. But during the process of CPR, so the perfusion which affects the important organs, that will depends upon the outcome of the patient. That is the survival of the patient. So usually the retinal circulation, the morbidity and mortality is very high if you are not taking the proper precautions. So let's come to the definition of the retinal spontaneous circulation. So retinal spontaneous circulation is a resumption of a sustained heart rhythm that perfuses the body after cardiac arrest. So after cardiac arrest, what happens? The heart rhythm will resumes. Okay. So that is the definition. So what is the pathophysiology of the retinal post-heart syndrome? So we have to take care of all these four things because these are all the four things that will decide the successful outcome of the patient. That is a persisting respiratory pathology. So anoxic brain injury during cardiac arrest, so there is no oxygen. So hypoxia leads to anoxia, the time the brain injury will occur. And post-cardiac arrest myocardial dysfunction and systemic ischemia and reperfusion response. These are all the four things we have to comment and we have to treat. Otherwise, the successful will be decreases. So regarding the persistent respiratory pathology, the precipitating etiology that leads to the cardiac arrest needs to be rapidly identified and addressed. What is the most common pathology? The coronary thrombus, which causes the myocardial infarction. So other non-coronary causes that can lead to cardiac include hypoxia and pulmonary embolism and sepsis. These could be immediately identified and have treated. Second thing is anoxic brain injury. The reperfusion that occurs after a period of cerebral hypoxia results in the formation of free radicals. This activation of the free radical, they will cause cell death and signaling pathways, causing the disturbance in the cerebral microvascular hemostasis. So this reperfusion injury that can continue for hours to days and is aggravated by additional insults such as fever and poor glucose control and hyperoxia. So we have to treat the fever and we have to monitor the glucose, we have to control the glucose, and we have to avoid the hyperoxia in future. The symptoms of anoxic brain injury includes coma, seizures, myoclonus, various degrees of neurocognitive dysfunction, finally brain death. So you have to take care of the anoxic brain injury. What the post-cardiac arrest myocardial dysfunction? So there is hypokinesia of the cardiac muscle associated with a significant drop of left ventricular ejection fraction, especially in the first 24 to 48 hours of the retinal spontaneous circulation. So it occurs despite the preserved coronary blood flow also. So this decreased left ventricular ejection fraction manifests as a tachycardia, hypotension, and poor cardiac output and elevated left ventricular and diastolic pressure. So another thing is systemic ischemia and reperfusion response. So whole body hypoxia, ischemia, followed by the post-recession recurrent spontaneous circulation. Reperfusion results in the systemic inflammation and endothelial activation and the activation of the immunological and coagulation pathways. So the hypoxia will activate the systemic inflammation and endothelial activation and immunological and coagulation pathways activation. So this resembles the pathophysiology occurring during severe sepsis and increased risk of multiple organ dysfunction syndrome. This clinical manifestation of systemic ischemia leads to the fever, altered oxygen consumption, as well as increased susceptibility to infection. So that's why we need a team approach to treat the patient after recovery from the successful CPR. So well-coordinated multidisciplinary efforts with participation of physicians from the disciplines of emergency physicians, and critical care intensive care physicians, and cardiology physicians, and neurology physicians, and anesthesia physicians. Finally, nursing care is also very important because entire monitoring is carried by the nursing care. So these are all the team approach is very important to increase the successful in a patient after recovering from the CPR. So what is the scope of post-resuscitation care? So the following areas need to be addressed to improve the outcome. So what are the areas we want to address? First, we have to identify and treat the cause of cardiac arrest. So we have to identify and treat the cause of cardiac arrest, and we have to manage the airway and ventilation, and you have to manage the hemodynamics, and you have to take care of the targeted temperature management previously. Now it is converted to the therapeutic hypothermia, and we have to monitor the proper glucose levels, that is glycemic control, and seizure management. Finally, neuroprognostication should be taken care of. So identification treatment of the cause of cardiac arrest. So what are the a good history of the events leading to the collapse and careful physical examination and basic investigation. Good history, careful physical examination, and basic investigation help us to determine the cause. What are the different causes? One is a coronary disease, second is acute pulmonary embolism, third is a cardiotoxic drugs, fourth is a metabolic disturbances, fifth is sepsis. These are all the different causes the patient may go into the cardiac arrest. So coronary artery disease, as soon as possible, the following ROIC, only ECG should be performed to diagnose the first segment elevation myocardial infarction and immediate coronary angiogram arranged. So studies done by the Dumas and Kino in a series of patients who underwent coronary angiography following cardiac arrest. A coronary artery lesion was found in 96% of the patient with STEMI and in 58% of the patient without ST elevation on ECG. So STEMI is the most important cause. So another study done by the Laurent and Monchi. So these myocardial and neurological functions can improve after percutaneous coronary interventions following cardiac arrest. So coronary angiography is needed because most cases are affected the coronary artery lesion. So 96% of the cases they will affect according to the Dumas and case. So immediate coronary angiography we have to arrange. Multiple studies have demonstrated improved survival to hospital discharge as well as improved neurological favorable outcome also with the emergency coronary angiography patient with a ST elevation after cardiac arrest. So if you diagnose ST elevation of myocardial infarction, you have to do the emergency coronary angiogram. Some patients are hypertensive despite of revascularization. They may need the mechanical augmentation by the intra-aortic balloon pump or extracorporeal membrane oxygenation. So persistent hypertension patient will take the help of IABP also. So thus immediate coronary angiography should be performed on out of hospital cardiac arrest with the suspected cardiac etiology and STEMI on the ECG following ROSC class 1 recommendations. So class 2A recommendation is also reasonable to perform the emergency coronary angiography following ROSC in unstable patient with suspected cardiac etiology but no ST elevation. So in unstable patient, you are suspecting any cardiac etiology. So emergency coronary angiography should be done. That is a class 2A. So all patients should undergo continuous cardiac monitoring for arrhythmias in the period following the cardiac arrest. So post-cardiac arrhythmias are more common. So arrhythmias should be managed appropriately as a resuscitation guidelines as per the resuscitation guidelines. So second cause is acute pulmonary embolism. So cardiac arrest due to pulmonary embolism often not obvious account for the 22 to 2 to 10% of the cases. So indicators of this cause include poor arterial oxygen saturation following the retinal spontaneous substance appropriate ECG. What are the ECG signals that will occur acute pulmonary embolism? Sinus tachycardia, complete or incomplete RBBB, right ventricular strain pattern, right axis deviation, dominant RV1 V1, and right atrial enlargement, that is P pulmonary we can see, and S1Q3T3 pattern, clockwise rotation, and atrial tachycardia, sometimes atrial fibrillation, flutter, and atrial tachycardias. These are all the different changes that will occur in a pulmonary acute pulmonary embolism patients. You have to diagnose with according to the clinical condition, that is a poor arterial oxygen saturation along with the ECG changes. So this acute pulmonary embolism, current guidelines, they do not support the routine use of fibrinolytics during cardiac arrest. But following return spontaneous circulation, it is preferable to confirm the diagnosis of pulmonary embolism on imaging before fibrinolysis is initiated. When direct imaging is unavailable or unsafe because of the patient unstable condition, fibrinolytics may be used in the post-cardiac arrest patient who are suspected to have a collapse from the severe pulmonary embolism. That is a patient with a sustained hypotension. That is a systemic blood pressure less than 90 mm of Hg for at least 15 minutes, or the patient requiring the inotropic support and not clearly due to the cause other than the PA, and high clinical pretest probability of PE and right ventricular dysfunction, bedside transfer echocardiogram. So, when direct imaging is unavailable, or if the imaging is taking unsafe for the patients, in such conditions, you have to give the fibrinolytics if you suspect the severe pulmonary embolism. Why? How to suspect severe pulmonary embolism? Sustained hypotension, that is systolic blood pressure less than 90 minutes for at least 15 minutes, and the patient needs a requiring inotropic support, and this hypotension not clear cut. There is no other cause other than the PE. So all other causes excluded for hypotension, then you can, and high clinical pretest probability of PE and RB dysfunction and bedside transfer capability. These are all the other things you have to diagnose the pulmonary embolism. Then you have to supplement the fibrinolytics. So let's come to other things, cardiotoxic drugs. Drugs such as tricyclic antidepressants and cardiac glycosides and recreational drugs are the main pharmacological agents that result in cardiac arrest. So since more cardiotoxic are water soluble and they may be excreted by the kidney, so forced alkaline diuresis may be employed. If you are suspecting the cardiotoxic drugs, first thing is what are the forced alkaline diuresis. But this is a slow process with the mechanism of excretion of the drugs. So the use of intralipids. Second thing is, one is we have to use the forced alkaline diuresis. And second thing is that you use the intralipids to enhance the elimination of cardiotoxic drugs. They may be considered once the ROS is achieved. So if started before collapse, the prolonged cardiopulmonary resuscitation may be required to allow time for these agents to exert their effects. So these agents must be continued at least for 24 hours following the ROS. If cardiotoxic agent is known, if available antidotes, they may be administered. So frequently massive drug overdose resulting in cardiovascular collapse required rapid removal of via hemodialysis. However, this may only be considered if the patient has attained ROIC and supportive care programs. So for cardiotoxic drugs, what you have to do? You have to do the forced alkaline diuresis. Second thing is the intralipid. Third is the hemodialysis. These are all the three things you have to. And if there any specific drug you have to supplement the antidotes to reverse the effects of the drug. So what are other things? Metabolic disturbance that will cause a cardiac arrest. So number of metabolic disturbances, those are hyperkalemia, hypokalemia, hypercalcemia, they can cause a cardiac arrest. So ECG following ROS may be the only initial clue to the diagnosis. So we can diagnose hyperkalemia, hypokalemia by the ECG. So treatment to curb this metabolic disorder initiated during registration or following ROS must be proceed in tandem with other supportive care. So for instance, hyperkalemic patients would require the calcium gluconate and glucose plus insulin in addition to the hemodialysis to remove the excessive potassium load. While the hypokalemia patients, we have to replace the potassium in hypokalemia patients. The hyperkalemia patient, we have to use the calcium gluconate and glucose plus insulin in addition to the hemodialysis. So these are all things. How to diagnose by the ECG. So hypercalcemia, what is the management hypercalcemia? First thing is we have to aggressive IV hydration, followed by the second step IV bisphosphonates and calcium, and followed by the refractory cases, we have to take the help of gallium nitrate densumal, and we have to use the volume overload, the hypercalcium volume over, we have to use the loop diuretics. If the hypercalcium is renal failure, dialysis with the low calcium bar. And in lymphoma leukemia, you suspect you have to consider the steroids for the treatment of the hypercalcemia. So we have to treat the hyperkalemia, hypokalemia, hypercalcemia. These three things are you have to treat. And sepsis, last thing. Sepsis is one of the major cause of the cardiovascular collapse. Once you suspected, the blood culture should be obtained and the appropriate intravenous antibiotic should be administered in addition to the identifying source of infection and appropriate management. So empirical antibiotics should be started After coming the blood cultures, then you have to do specific antibiotic to treat the sepsis. And protocolized resuscitation of patients using sepsis care bundles have been shown to decrease the mortality in a group of patients. The second thing is, one thing is respiratory causes. Second thing is airway and ventilation management. So awake patients who are able to maintain their airway and have a spontaneous respiratory can be monitored without intubation. The patient is awake, no need of intubation. You have to take the oxygen supplement. Supplemental oxygen is recommended to maintain this SpO2 between the 94 to 98%. So 94% is ideal. So following ROSC, comatose patient will have a definitive airway. If the patient is in coma, you have to secure the definitive airway established and mechanical ventilation you have to commence. The patient is coma, we have to secure the definite airway and when mechanical ventilation should be done. So previous guidelines recommend the titration of supplemental oxygenation to prevent the hypoxia, avoid the prolonged periods of hypoxia. So two things we have to take care of. We have to prevent the hypoxia and we have to avoid the hyperoxia also. Both are dangerous in ROSC patients. So there is increasing evidence to suggest that excessive oxidative stress during the hyperoxia may harm the various organs, causing the neuronal damage as well as irreversible changes within the alveolar space. So severe hyperoxia was independently associated with decreased survival to the hospital. So following ROSC, hyperoxia during the reperfusion phase with 100% oxygen is to increase the brain lipid peroxidation and greater metabolic dysfunction and neurological degeneration. These are all the things that will deteriorate the patient of the rare vessel. So these concerns and their impact on the short-term functional outcomes have resulted in calls to ventilate with the room air fraction of FiO2 titrated to the pulse oximeter 94 to 98%. So your target of the oxygenation saturation is 94 to 98% only. So you should not allow the patient to go with hypoxia and you should not allow the patient to go with hyperoxia, that is 100% oxygen also, because both are dangerous in this patient. So awake patients who are able to maintain the airway spontaneous maintain. Supplemental, there is 1994% of patients. Already repeated things. So once a reliable SpO2 can be measured, ABG is obtained to measure the oxygenation. It is important to titrate the FiO2 to maintain the oxyhemoglobin saturation at a 94 to 98% in pulse oximetry. Third thing is hypocapnia. So hypocapnia is associated with the worst neurological outcome. So it is suggested that initial ventilator setting should begin with a low tidal volume, that is 6 to 8 milligram per kg weight, and ventilator rate should be low, that is 10 to 12 or 8 to 10 per kg. Because aim of the optimal ventilation should be to maintain the normocarbia. So normocarbia means end-tidal carbon dioxide should be 30 to 40 mm of Hg, or partial pressure of arterial carbon dioxide 35 to 45 mm of Hg. So your ETCO2 must be 30 to 40 mm of Hg. So hyperventilation is not recommended. If the hypocapnia also dangerous. So it decreases the partial pressure of carbon dioxide, which in turn decreases cerebral blood flow, causing cerebral vasoconstriction and aggravating the anoxic brain damage. So that's why hypocapnia, we have to avoid hyperventilation, we have to avoid. Minute ventilation should be titrated, guided by serial ABG measurements. Next thing is hemodynamic management. So hemodynamic management, post-ROSC patients are often hemodynamically unstable and their management can be challenging. Although the optimal hemodynamic goals remain undefined, ensure to maintain the adequate cerebral and coronary perfusion pressures as well as the blood flow to the other vital organs must be instituted. So we have to maintain the adequate cerebral perfusion pressure, adequate coronary perfusion pressure, and other vital organs, other organs perfusion pressure. The main goal of hemodynamic management is to avoid the hypotension and to achieve a systolic blood pressure of at least 90 mm of Hg or mean arterial pressure of 65 mm of Hg following resuscitation. So we have to maintain the systolic blood pressure at least 90 mm of Hg or mean arterial pressure around 65 mm of Hg after resuscitation. So these to be attained by targets of other hemodynamic parameters are cardiac output, cardiac index, and mixed and central venous oxygen saturation or not product. They are still undefined, but can vary among the patient based on the specific condition. We can also assess the hemodynamic parameters by measuring the cardiac output, cardiac index, and if the facilities are available, mixed and central venous oxygen saturation. And you output we can see. So main target is you have to maintain the systolic blood pressure 90 mm of Hg and the mean arterial pressure 65 mm of Hg. So intravenous fluids and inotropic should be titrated to optimize the blood pressure, cardiac output or urine output, and you have to administer very judiciously. So we have to optimize the blood pressure, that is systolic to 90 and diastole and mean artery 65, and we have to maintain the cardiac output, we have to maintain the adequate urine output. So the aim is to optimize the cardiac output, tissue perfusion, oxygen delivery, and to achieve an SpO2 more than or equal to 70%. Although there is no gold standard or pharmaceutical agent that may be used to support circulation, including adrenaline, noradrenaline, dopamine, dopamine. Dosages must be adjusted on the parameters monitored. So echocardiography should be usually performed at 24 to 48 hours following the ROSC to monitor the ejection fraction and to rule out the regional malmotion abnormalities because they will affect the hemodynamics. So another important thing is targeted temperature management or therapeutic hypothermia. So hypoxic brain injury is a major cause of morbid mortality following resuscitation. So this target temperature management, the therapeutic hypothermia following ROSC confers a neuroproduction through a variety of mechanisms. So new evidence have demonstrating the efficacy of broader range of temperatures, including normothermia, and the prevention of fever has led to the increasing the use of term the TTM, the targeted temperature management over the therapeutic. Previously, what we are calling as a therapeutic hypothermia. Now we are using the targeted temperature management instead of therapeutic hypothermia. So target temperature management should be initiated immediately in a resuscitation adult patients who are comatose at ROSC, regardless of the first recorded rhythm, that is shockable or unshockable, or sitting cardiac arrest outside or inside the hospital. So you have to initiate it immediately in a patients who are comatose after ROSC. So TTM should be maintained for at least 24 hours. So lower temperature targets are associated with increased risk of sepsis, dysarthrias, and coagulopathy should be avoided. So less than hypothermia, there is a less than 34 to 36, less than 36 temperature. Hypothermia it will causes increased sepsis, bradyarthrias, coagulopathy. Fever should be prevented in all patients with cardiac arrest and abnormal loss of consciousness. Thus, the maximum target temperature of cooling for all patients should not exceed 36 degrees centigrade. Temperature management may be initiated by a variety of methods. So what are the different methods? There 34 to 36 is the optimal target temperature. Should not cross 36, it should not down to 34. So how will it be achieved? By the surface cooling with ice packets or cooling blankets applied to the groin, axilla, neck and large area of skin, or helmet device continuous aqueous glycerol solution, cool glycerol solution that will decrease temperature. The second thing is judicial amount of cold infusion, that is 2 to 4 degrees centigrade infusion, especially for normal saline or balanced electrolyte fluids, or as the large volumes may be associated with increased risk of pulmonary edema. So we should not give the large volumes because this cold they will increase risk of pulmonary edema. So some device that will initiate the evaporative transnasal cooling, and sometimes endovascular cooling catheters also we can use. These are all the 4 things who can achieve the targeted temperature management. So this TTM should be how to monitor the target temperature management during the initiation of TTM. The maintenance of target temperature, the core body temperature should be monitored using a bladder temperature catheters or esophageal or central venous probes. So axillary or tympanic membrane, oral or even rectal temperature differ from the core body temperature, and they are unreliable also. So target temperature should be maintained for at least 24 hours before the rewarming. So how to monitor the target body temperature using the bladder temperature catheters and esophageal and central venous probes. They are the ideal. You should not depend upon the axillary, tympanic membrane, oral or even rectal temperatures also. So what are the side effects? Shivering, a side effect hypothermia, has an adverse impact on the management of target temperature, and if necessary, the patient should be sedated, paralyzed to reduce the undesirable effects. So shivering increases the oxygen consumption. So that's why for avoiding shivering, you can sedate the patient and you can paralyze the patient. So neurological monitoring using electroencephalogram or bispectral index of brain system is necessary during paralysis in order to detect the seizures and awareness. If paralytics are needed, analgesia, sedation should be titrated and necessary for the mechanical condition and comfort of the patient. So you should not allow the patient to go for shivering. If it is severe, you could take the help of sedation and analgesia sometimes and paralyzing patient also. And rewarming. The patient should be gradually rewarmed at approximately 0.25 degrees centigrade to the 0.33 degrees centigrade per hour. So not exceeding the 0.5 degrees centigrade per hour until they return to the normothermia. So rapid rewarming can lead to the cerebral edema, seizures, and hyperkalemia. So close monitoring of electrolytes and coagulation indexes should be performed at 4-hour intervals. So following rewarming, the focus should be placed on the avoidance of rebound hyperthermia. That is the occurrence of hyperthermia in the first few days after cardiac arrest. It is associated with a severe neurological injury and worse than the outcome will be worse. So that's why you have to aware of the rebound hyperthermia after rewarming. So other complications are some potential complications may be increased susceptibility infection, hypotension, coagulopathy, arrhythmias, sometimes hyperglycemia and electrolyte imbalance may occur. So appropriate care must be taken to prevent the infection. Antibiotics should be used if needed, and hemodynamic support electrolyte level should be also monitored, and insulin therapy initiated to prevent the hyperglycemia. And patient undergoing TTM needed to be managed in the intensive care unit with close monitoring of vital parameters. These are all the other complications of TTM. So next thing is glycemic control. Hyperglycemia following ROSC have been associated with an increased risk of mortality and worse neurological outcome. So we should not allow the patient to go for hyperglycemia. Similarly, hypoglycemia also associated with poor outcomes in critical ill patient. So we should not allow the patient to go to hyperglycemia. We should not allow the patient to go to hypoglycemia. The optimal range of blood sugar in these patients remains unknown, but still the strict blood sugar control with intense insulin therapy increase the risk of hypoglycemia, which has been associated with increased mortality. So blood sugars will be maintained 6 to 10 millimoles per liter. So we should not maintain the strict blood sugar control, but we should not allow the patient to go to the less than 6 millimoles per liter, to go to the more than 10 millimoles per liter. So a study comparing strict versus moderate glucose control did not show any mortality benefit. The strict monitoring the post cardiac respiration. So you can maintain the strict or moderate glucose control, but your target should be 6 to 10 millimoles millimoles per liter you have to maintain. Seizure management and neuroprognostication. The prevalence of seizures in a post-cardiac patient is 12 to 20%. A seizure is a detrimental to the brain function. It should be treated promptly with the benzodiazepines, other anticonvulsant medications. So there is no role of prophylactic administration of anticonvulsant drugs in ROSC patients. Electroencephalogram should be performed without delay, and reading should be monitored frequently or continuously in a composed patient following ROSC. Final thing is neuroprognostication. Neuroprognostication post cardiac arrest patient is clinically very challenging. So brain injury is a result of initial ischemic injury followed by the reperfusion injury occurring during the hours to days of ROSC. Features indicating brain injury in post ROSC patients include coma, seizures, myoclonus, and various degree of neurocognitive dysfunction, ranging from the memory deficit to the persistent vestibular state, finally brain death. So, neuroprognostication when to do? The earliest time for the prognostication for the post ROSC patient treated with TTM is 72 hours after return to the normothermia. So we have to do the neuroprognostication with the target temperature with the TTM 72 hours after returning the normothermia. In patients who are not treated TTM, prognostication should perform 78 hours after the cardiac arrest. Okay, so as the decisions on do not restrict orders, DNR orders, or withdrawal of care should be avoided for 72 hours following the ROSC. So wait for 72 hours. However, in cases where the patients have an underlying terminal diseases, that is a brainstem herniation, other non-survivable situations, withdrawal of care must be considered before the 72 hours. So in bad patients, we can neuroprognosticate before the 72 hours, but usually for 72 hours after TTM. So conclusion, so management of cardiac arrest patients for ROSC is a complex and it requires multidisciplinary approach. All the specialties must involve. All hospitals should establish standardized protocol for the initiation, management of bundle of post-harvest care, which may eventually lead to the improve the patient outcome. So you have to take care of all the things. Then only you can increase the success rate of a patient's successful recovery after CPR. That is the ROSC patients. Thank you.